Today our topic is hypersensitivity reactions, right? So hypersensitivity reaction, what is really meant by this, right? As the name implies, that probably hyper mean exaggerated. Hypersensitivity reaction, the literal meaning of this is exaggerated immune reactions. But you remember, all hypersensitivity are not exaggerated. The point which you have to remember, all hypersensitivity reaction are not exaggerated. So this is a misnomer. The real concept of hypersensitivity reaction is any tissue damaging immune reaction. So any tissue damaging immune reaction in your body should be considered hypersensitivity reaction. It may be truly hypersensitive, mean it is a truly exaggerated response, or sometimes even very appropriate immune response may do some damage in your tissue, is that right? And even very appropriate immune responses may be hypersensitivity reaction. So the best way to define what is hypersensitivity reaction, hypersensitivity reaction is any immune reaction which damages your tissue. Is that right? Now, hypersensitivity reactions are very commonly classified into 4 types, right? Hypersensitivity reactions are very commonly classified into 4 types. Type 1, type 2, type 3 and type 4. The 4 types of hypersensitivity reaction, type 1, type 2, type 3 and type 4. The art of understanding is that you must be able to differentiate every type from the other types. Is that right? First, you have to remember type 1, type 2 and type 3. All of them involve antibodies. All of them involve antibodies. So this is also antibody mediated. Type 1 is also antibody mediated, type 2 is also antibody mediated, type 3 is also antibody mediated, and type 4 does not involve antibodies. Type 4 immune reaction does not involve antibodies, it depends only on the cells. So that is why it is also called cell mediated hypersensitivity reaction. Hypersensitivity reaction. Now the point which you have to understand is in type 4 cells are involved, immune cells are involved, but no antibodies involved. In first, second and third, antibodies are always involved, and even some immune cells may also be involved. So real difference is in type 1 and type 2 and type 3, they do involve antibodies and type 4 does not. Is that right? There is no antibody involved into type 4 hypersensitivity reaction. Now, because type 1, 2 and 3 all of them involve antibodies, let's see how they are different from each other. Is that right? We'll discuss their differences a little bit, then we'll go to detail of every type, right? Now, in type 1, first of all, we talk about antigens. In type 1, antigens are usually free antigens and foreign antigens. Free and foreign antigens. What I mean by this? For example, pollen grains enter into your respiratory system and start some hypersensitivity reactions. If pollen grains are going, of course they are free antigens, they are not fixed in your tissue. They are free antigens and of course they are foreign. Or for example, that some house dust mite, you are developing hypersensitivity to house dust mite material. Is that right? Now again that is foreign antigen and that is free antigen. Or you develop a hypersensitivity reaction to penicillin, right? So that is foreign and free. Now, antigens in type 1 are always foreign and free, right? But antibodies in type 1 are antibodies in type 1 are, yes, are always IgE. Antibody type is IgE, and this IgE is fixed on mast cells or basophils. Mast cells are present in tissues and basophils are present in circulation in very small amount. Now look, what really happens in type 1 hypersensitivity reaction, that in type 1 hypersensitivity reaction, antigen is free but antibody is bound. Antibody IgE is free in the plasma in very small amount, and most of the IgE antibody is bound on the mast cells and the basophils. So here antibody is fixed and antigen is free. Now let's come to the type 2. In type 2 reaction, what really happens, that antigen is always fixed and intrinsic to the tissue on which reaction occurs. For example, in type 2, antigen may be fixed on the surface of RBC, then reaction will occur only on the RBC. Or antigen may be fixed and intrinsic to glomerular basement membrane, then reaction will only occur on the glomerular basement membrane. Now listen, how type 1 and type 2 are different in one way. In type 1, antigen is always foreign to tissue to which reaction is occurring. In type 2, antigen is always fixed and intrinsic. There are 2 points to be noted. Here antigen is fixed on the tissue or in the tissues, and it is intrinsic to the tissues. For example, look, if this is an RBC and this is an antigen on the RBC, if immune system is going to react against this antigen, then this antigen is intrinsic part of this RBC and this antigen is fixed on the RBC. Or if there is glomerular basement membrane, suppose this is glomerular basement membrane and this is an antigen which is a part of glomerular basement membrane. And if immune reaction occurs against this antigen, again antigen is fixed, it is not freely circulating antigen, and it is intrinsic to the tissue. RBC antigen is also fixed on the RBC membrane. This antigen is not free into body fluids, or it is not free in plasma. Is that right? So the very, very important point is worth repeating, that in type 2 reactions, antigen is always fixed and part of the tissue to which reaction is occurring. Is that right? Am I clear? Right? Now, so antigens are intrinsic to the reactive tissue and antigen is fixed. And antibody is usually here, antibodies usually is, what type of antibody is there? Usually it is IgG or IgM, or it is immunoglobulin IgM, right? General Motors GM. Type 2 hypersensitivity reaction does not involve IgE. It involves IgG or it involves IgM, right? Now, another thing, the effector system. Listen, keep on comparing. In type 1, antigen was foreign. In type 2, antigen is intrinsic to the tissue to which reaction is occurring. This antigen may be original, or this antigen may be modified by some drug, or it may be modified some microbe, but antigen to which reaction is occurring is intrinsic, right? Here antigen is free, there antigen is fixed. Okay, in type 1, antibody is always IgE, and antibody is fixed mainly on the mast cell and basophil. Very little IgE is free in the plasma. So most of the IgE with which the reaction really occur is fixed on the mast cells or basophil. Now listen, here immune complex will form where? On the mast cell, because antibody is sticking to the mast cell, the basophil, so antigen has to come to the mast cell and basophils. So antigen and antibody will react only on the surface of mast cells and basophil. Is that right? But here, because antigen is fixed, antibody has to come to the target cell or target tissue. So an immune complex will form, antigen antibody reaction will form only and only on target tissue. Now look here. Do you think here antigen or antibody complexes will be found free in circulation or free into tissue? Answer is no. In type 1, because antibody is fixed, even though antigen is free, but antibody is not free. So when antigen antibody fuse, right, they fuse on the surface of mast cells and basophils. So fused antigen antibodies are not found into tissue fluids. Is that right? In type 2, again come, the antigens are part of the cell membranes, or antigens are part of the particular glomerular basement membrane or alveolar basement membrane or any tissue. Antigens are fixed and intrinsic. Even though antibodies are free here, but antibody have to go to antigens. So antigen antibody reaction will occur in type 2 always on the target tissue surface. In type 2, antigen antibody reaction will occur always on the target tissue. And in type 1, antigen antibody reaction will occur always on mast cells and basophils. So in type 2 also and type 1, in both cases, you will not find freely circulating antigen antibody complexes in body tissues or body fluids or into circulation. Is that right? Why? Here antibody was fixed and there antigen was fixed. Now we come to the type 3 hypersensitivity reaction. In type 3 hypersensitivity reaction, what really happens, that antigen may be extrinsic, exogenous, or it may be endogenous. In case of type 3 hypersensitivity reaction, antigen may be exogenous or it may be endogenous. Now, it means this point will not help us, attention please, this point will not help us to differentiate type 3 from 1 and 2. Where is the difference? Let me tell you. In type 2, difference is that in type 3, antigen may be exogenous or endogenous, but this is free. Antigen is always free. It may be endogenous antigen or it may be exogenous antigen, but it is free. And what about antibody? Antibody in case of type 3 is IgG or IgM, but it is also, yes, free. Here antigen is free as well as antibody is free. So it means antigen antibody can react into tissue fluids or into circulation and make free immune complexes. So it means the hallmark of this situation is formation of free immune complexes. And this is the unique point to type 3, with that free immune complexes are not formed in type 2 because antigen is fixed, and free immune complexes are not formed in type 1 because antibody is fixed. That is why conventionally we call type 3 reactions as immune complex reactions, because we can find immune complexes in free form. Ideally, ideally this should be called free immune complex disease, right? But conventionally or traditionally, they simply call it immune complex mediated disorders. Let's recap. So what's hypersensitivity reaction? It is any immune reaction which damages our tissue. It may be hyper response, it may not be hyper response, it may be a very appropriate response. But again, any tissue damaging reaction is hypersensitivity reaction. Hypersensitivity reactions are classified as type 1, 2, 3 and 4. Type 1, 2 and 3, they are what? Antibody mediated. And type 4 does not involve antibody, it purely depends on immune cells. So it is also called cell mediated hypersensitivity reaction. Now, it's very important to differentiate between type 1, 2 and 3, because type 4 is too easy to differentiate, that any hypersensitivity reaction which does not involve antibody and which involves only the immune cells must be type 4. So how do you differentiate in type 1, 2 and 3? The one way to differentiate is, in type 1, antigen is always foreign and free. Foreign and free. Antigen is always foreign and free, like pollen grains or like you can say some food stuff. Some people develop allergy to egg, or some people develop allergy to seafood, some people develop allergy to their wives, some people develop allergy to their teachers, I don't know. So, but I'm not including last two examples that are psychological hypersensitivity reactions. Let's come to the immunological hypersensitivity reaction where antigen is foreign and it is free. Is that right? When we talk about type 2 hypersensitivity reaction, antigen is in part of intrinsic tissue. Antigen is fixed and part of and intrinsic to the tissue on which reaction is occurring. Antigen is fixed and intrinsic to the tissue to which reaction occur, right? And in type 3, antigen, in type 3 reactions, antigen may be exogenous, or it may be endogenous, but it is free, and even if it is endogenous, it is free. For exogenous example is, if streptococcal antigens enter into your body, they may be freely circulating, in the end they get deposited into glomeruli, post-streptococcal glomerulonephritis. Or endogenous antigens are free, like DNA molecules may be free in the blood in case of SLE, systemic lupus erythematosus. And if anti-DNA antibodies react with the circulating DNA, they make immune complexes. Is that right? Examples of type 2 antigens are fixed and intrinsic antigens. For example, antigens as a part of RBC membrane, antigens embedded in the neutrophil membrane, antigens present on the platelet membrane, antigens present on glomerular basement membrane, right? But antigens are free, not free, they are fixed and intrinsic to the tissues. Here antigens are free. Now we come to the antibody involved. What is that? Antibody involved. Here antibody is always IgE, right? And fixed mainly fixed. Very little IgE is free in the plasma, but the antigen antibody reaction occur with the fixed, right? So we say, and IgE is the antibody and it is fixed on mast cells and basophils. Very good, basophils. Mast cells are present in tissues and basophils are present in circulation, right? Then in type 2, yes, it's very important to understand, in type 2 antibody is IgG or IgM, and of course this is even free in the body tissue. But remember, antibody is free here, antigen is fixed. So because antigen is fixed on the target tissue, so immune complex will always form on the target tissue, right? And no, we should write specially, no free immune complexes, no free immune complexes in type 2. Again in type 1, even though antigen is free but antibody is fixed, so antigen antibody reaction will always occur on the mast cell of basophils. Again there is no free immune complexes, no free immune complexes. But when we come to the type 3 reactions, antigen may be exogenous or endogenous, but antigen is free, and at the top even the antibody is also free. Antibody may be IgG or in type 3 reaction it may be IgM, but the important point is it is free. So as antigen is free and antibody is free, so free immune complexes may be found, yes, in circulation, or free complexes may be found in circulation or tissue fluids if reaction is local type, tissue fluids, right? So this is a very, very big difference. Is that right? Now, the detail of, now I will go for every test into detail, every type into detail. I will go into detail of type 1, then we will go into detail of type 2, and eventually in the detail of type 3 and 4, right? Is there any confusion among them? So if I say that a foreign antigen come into your body and you have made IgE against that, what is this? Type 1. And if I say that there is a stem cell in my bone marrow and there is a protein on my stem cell, an antibody form and react against my stem cell proteins, what is this? Type 2. And if I say that there is some circulating drug in my blood and against that drug I have made antibodies, and antigen antibody complexes form in circulation and deposit into different places and damage, what is this? Type 3. Is that right? And if I say some virus enter in my body, right, and or okay, if I say fungus enter in my body and against the fungus cell mediated immunity started damaging and no antibodies involved, what is this reaction? Type 4. Now we'll do randomly without any sequence. We have, for example, some horse serum is injected in your body. Horse serum is injected into Abdul Salam body, and horse serum for Abdul Salam body will be self or foreign?
Would be self or foreign?
Yeah. Your body will perceive horse serum as your own serum or foreign serum? Hopefully foreign.
Type 1.
No. Just first listen. First listen. My question is, if I introduce horse serum into your body, horse serum will be perceived by your immune system as self proteins or foreign proteins?
Foreign protein.
You are very sure?
Positive.
Okay, maybe horse is not sure. Anyway, if horse serum come into your body and you make antibodies against the horse serum, we are just supposing, you make antibodies against the horse serum proteins, and horse serum protein and your antibody make complexes and moving into your circulation and deposit here and there. What is this reaction? Type 1, 2 or 3? Horse serum proteins have entered into your body, of course by injection. Is that right?
And it's foreign.
And it's foreign, right? And you have made antibodies, and antigen antibody complexes are circulating in the blood. Type 3. Right, now another example. If a fungus come into your body and against the fungus you have made IgE and that is loaded on the mast cells, what is this reaction?
Type 1.
Type 1, excellent. And if I say that I give you a drug and that drug goes and bind with the antigens on RBCs. Drug goes and modify the antigens on RBCs. Drug goes and modifies the antigens on the RBCs, and your immune system make antibodies against modified proteins of the RBCs. What drug has done? Drug fused some of its part with the antigens of your RBCs, and RBCs antigens are modified, and against these modified antigens, which are your own intrinsic antigens, immune system make antibody, and now immune system will attack only RBCs, not rest of the body. Type 2. So now you really understand it. I'm happy. Now we'll go into detail of type 1. Now let's take an example of type 1 reaction. We'll define this reaction later. We'll define type 1 hypersensitivity reaction later. Let's start with a story to understand it. Right? One of our students can come here. Mr. Rahul, you will come here?
No.
You don't want? Okay, Abdul.
My eye is bad. You guys go. What do you guys go? I have a bad eye. And I look like a bum today. Someone go. I didn't shave.
Someone has to come here.
No.
We'll take another. Okay, Rahul is coming. You bring a chair here because you have to sit and as a perfect example of type 1 hypersensitivity reaction. Right? Yes, good. You sit here. Now, I will tell you a story about Mr. Rahul, how he developed type 1 hypersensitivity reaction, right? He passed his USMLE step 1 with 99 score, right? and he wanted to celebrate with his, okay, he was in his country when the result came with his family. So he wanted to give them very good, party to his mother and father, sister and brother, not to girlfriend later on privately. Now, what really happens that he takes his family to a very special garden where there are new flowers, right? It's spring season and pollens are in the air. He also calls many of his friends, but not his girlfriend, many of other his friends. So all his family members and all his friends, they are enjoying in that garden and having good food, having good time, and pollens are going through their noses. All of them have noses, right? So pollens are going through their noses to their respiratory system. Now what happens? That pollen grains are foreign material. When they come into respiratory system, let's draw a respiratory system here. The respiratory system of one of your friend. Okay, respiratory system of one of your friend. Now what really happens that this is the pollen. When pollen is coming into respiratory system, right, there are two fates. Number one, respiratory system is having, these are special epithelial lining, and it has, what are these? Cilia. And these cilia are beating upward. One thing what may happen to this foreign substance or particle is that this pollen is beaten upward through the mucociliary mechanism. There's a mucus lining, right? Pollen is stuck into mucus lining and cilia are beating it upward. So mucociliary clearance will take the pollen towards the larynx. So most of his friends may swallow from the larynx the mucus, respiratory mucus along with the pollen, right, may be thrown from the larynx into esophagus and they will swallow it and throw the pollen wrapped into mucus into your acid-full stomach and destroy the pollen. This is one way. Second thing is that if pollen really come very distal, then ideally this pollen should be eaten up by a macrophage. So this macrophage is going to eat up this pollen. Normally what should happen, listen now carefully, normally what should happen that alveolar macrophages, respiratory macrophages should take up the pollen, right? And let's suppose this is macrophage, is that right? And here is macrophage nucleus, here is phagosome, and what is here? Here is pollen. So these are pollen antigens, Now what really happens that lysosomal enzymes will be released here, and in most of your guests, what really happens that pollen's proteins may be degraded up to amino acid, pollen's fats, lipids may be broken down to fatty acids, and pollen's carbohydrate may be broken down into monosaccharides, and all these basic components are recycled in the cell. You can say pollen antigens are completely destroyed. And if pollen antigens are completely destroyed, will there be any immune response? Answer is no. So what is happening that all of your friends there and your family member, whatever pollens go to the respiratory system, they destroy the pollen completely and they don't develop any immune reaction towards that pollen. But your case is different. What is your special case? That your immune system has decided to react against the pollen. Now we see that how his immune system is going to react against the pollen. Now this is your personal special venture. That your macrophages are different than others' macrophages. What you really do? Suppose this is your respiratory macrophage. Here is the pollen. Let's suppose I make your pollen colorful because it's going to develop a special type of problem for you, right? Pollen has come here. Now this is pollen and these are pollen antigens. What are these? These are pollen antigens, right? And here is macrophage nuclear material. Now what really happens? That even though lysosomes release their contents into this, but they break down the pollen antigen only partially. And this is the pollen antigen, and unfortunately his HLA genes, The genes on chromosome number 6. There is a chromosome number 6. Of course, you must be having one chromosome number 6 from your mother, another should be coming from your father. So, chromosome number 6 has special genes which are called MHC genes or HLA genes. These are making class 2 molecules. These genes are making special type of MHC class 2 molecule. One of the class 2 molecule react with the pollen antigen. Now this is the sad thing, because if class 2 reaction, class 2 molecule, MHC class 2 molecule is present in your macrophage, which can bind with this pollen, it means this pollen antigens will not be further degraded, rather these pollen antigens will be presented to the immune system. Remember, in other guests who went with you, they also had the pollen. The difference in you and other people is that other people who went with you did not make such class 2 which could bind and present the pollen. But you are unfortunately genetically programmed to make such type of class 2 molecule which could bind with the pollen antigen and present to the immune system. Now, as soon as class 2 molecule bind with the pollen, then further pollen antigen degradation will be halted. There will be no further degradation of antigen. Now this pollen antigen will be expressed on the surface of macrophage along with which molecule? MHC class 2 molecule. Whenever, now we can say this macrophage has taken up the foreign antigen and processed the foreign antigen with class 2 molecule, and now antigen with the class 2 molecule is ready to be presented to the immune system. So this macrophage will rush to the lymph nodes. There it will find a special type of T cell. It will find a special type of T cell, right? And what really it happens, this special T cell should have TCR. TCR. What is TCR? TCR is T cell receptor for the antigen. What is TCR? TCR is T cell receptor for the antigens. So unfortunately, in his body, he has such type of T cells which are having such antigens which can recognize pollen. Unfortunately, his body has, or immune system has, such type of T cell which are having such a receptor which could recognize pollen antigen. But most of the people who went with you, maybe even if class 2 molecule bind with the pollen, some of them may not have such T cell which could recognize the pollen antigen. Do you get it? Yeah. Now, second thing, that once TCR bind with the antigen, then second is another molecule here, and this molecule is called CD4. Yes, CD4 molecule. And this CD4 molecule react with class 2. If pollen antigen is processed with the class 2 molecule within the antigen presenting cell, in this case antigen presenting cell is macrophage, right? Antigen presenting cell took the pollen antigen, bind with the class 2, present to the appropriate T cells, and then it gives some co-stimulations also, which I will not discuss in detail now. But what really happens, that this T cell is activated, right? Of course, this molecule is CD3. So when TCR and CD4 are stimulated, they stimulate which molecule? CD3. The CD3 will give message to this lymphocyte nucleus, and its nuclear machinery will be activated. And this T cell's nuclear machinery, first of all, the first gene will be stimulated, and this gene will make interleukin 2. Then second gene will be stimulated, and that will make the receptor for interleukin 2. Second gene will make receptor for interleukin 2. So this interleukin 2 will react on the receptors on this T cell. Again, let me repeat it, that this T cell, as soon as this TCR and CD4 are stimulated via the CD3 pathway, it will activate the nucleus. And nucleus the first gene which is activated, it will produce interleukin 2. So this cell will start secreting interleukin 2 molecule. Secondly, this cell will start overexpressing for receptor for interleukin 2. Now, as soon as the receptor for interleukin 2 is stimulated, the receptor gives signal to the cell, and in the cell this gene is activated. This gene is concerned with mitosis. So this special type of T cells undergo mitosis, and when this T cell undergo mitosis, there are millions of such T helper cells are made, right, which are sensitive to pollen. Now what happened? That such T cells which are resulting, or you can say there's clonal expansion of this pollen sensitive T cell. You're getting it? That this unique T cell which had such TCR which could react with pollen antigen, this T cell will undergo autoproliferation or clonal expansion. What will happen? There will be clonal expansion. When there will be clonal expansion, these T cells will multiply. When these T cells will multiply, we say that his circulation is very rich, or in his body has become very rich in this unique subset of T cells. Once they have enough, once these T cells have proliferated enough, then they activate another group of gene. This gene will produce interleukin 4, and other gene will produce interleukin 5. And this reaction, that activation of the gene for interleukin 4 and 5, this occur into all group. So there's massive production of interleukin 4 and 5 in this body. Now, but unfortunately, interleukin 4 production in his body has been extremely excessive. There is unduly excessive interleukin 4 produced in his immune system. This was another fault. We'll see, because this excessive amount of interleukin 4 is must to produce IgE. Is that right? And this was another fault, that you activated interleukin 4 gene not with slightly increased activity but superly increased activity. So when interleukin 4 become extremely high, this help the cells, B cells, the plasma cell, to produce which antibody? IgE. Now, meanwhile, some of the pollen antigens may have gone, look, there is a B cell here. Now part 2 of the story. This is a B cell in his lung. Is that right? And this B cell have surface receptors. These are B cell surface receptors, and these are called BCRs. BCR means B cell receptor for the antigen. There was TCR, this is T cell receptor for the antigen. Here is B cell receptor for antigen, right? Now, actually some of the free pollen antigens bind with BCRs. Some of the free pollen antigens, right, bind with the BCRs, B cell receptors. Now this B cell which was sleeping, this B cell become active. This B cell has its own genetic program, and this activate the nuclear machinery of this B cell. And what happened? Look here. This gene is activated, and this gene produces a receptor for interleukin 4. This gene makes the receptors for, yes please, interleukin 4. These are interleukin 4 receptor. But there may be many B cells. There are other B cells also there. But only that B cell which had such BCR which could recognize pollen antigen, only those B cells start expressing which receptor? Interleukin 4. It means only this B cell will become sensitive to interleukin 4. Other bystanding B cell will not be sensitive to interleukin 4. Interleukin 4 has many functions. One of the function of interleukin 4 is that it act as B cell growth factor, because interleukin 4 in low and moderate concentration can stimulate the B cells, of course only those B cells which are expressing interleukin 4 receptors, and stimulate these B cells and force them to multiply. Now what happens? That these B cells will start multiplying, right? These B cells will start multiplying. You can say pollen sensitive B cells will start multiplying, right? This is called again clonal expansion of B cell. Here there was clonal expansion of T cell. Here there is clonal expansion of B cells. When B cells are clonally expanded, then what really happens that all of them start expressing, yes, all of them start expressing the receptor for interleukin 5, right? So what really happens that interleukin 5 will react with them, and when interleukin 5 will react with them, all of them will convert into plasma cells. All of them will convert into, under the influence of interleukin 5, all of them will convert into, yes, plasma cells. Plasma cells are active B cells. What are plasma cells? These are active B cells which have been appropriately stimulated, and they are oval cells with a nucleus which is cartwheel shaped or nucleus which is clock face shaped, and these active B cells or plasma cells have eccentric nucleus because they are having a very prominent Golgi apparatus, and this Golgi apparatus is so that these cells are planning to synthesize and export some proteins. Now what really happens? These all B cells have been working under the influence of interleukin 5. Interleukin 5 convert the B cell into plasma cell, but in the presence of very high amount of interleukin 4, these plasma cells start secreting the antibodies, antipollen antibodies. What antibodies? Antipollen antibodies, and these antipollen antibodies are belonging to the class, which immunoglobulin class? E class. So we say that all these, right? So what are these? Up to now there is no type 1 reaction. It is only preparation of the reaction. Antipollen IgE immunoglobulins. Now there is a big change in his body. That in his body, with the help of T cell, that is why, because these T cell help the B cell to convert into plasma cell and produce antibodies. So thus such T cells are called T helper 2. These are T helper 2 cells. We will talk later about T helper 1 when we talk about type 4 hypersensitivity reaction. So what are T helper 2 cells? These are those cells which can help the B cell to convert into plasma cells. Is that right? Now, there is a very special change in Raoul body which is not in his friends' change and parents or brothers and sisters, right? What is the change? The change is he is making antipollen IgE, and because this IgE has special receptors present on the mast cell. Let's suppose this is a mast cell. This is mast cells. Mast cells have unique type of receptors. Every mast cell they have unique type of receptors, as well as basophil they have also similar receptors, and these receptors love to bind which antibody? IgE. So as IgE is being produced by these plasma cells, IgE will bind with the mast cells. Now his mast cells and even basophils will be loaded by IgE, but yet type 1 hypersensitivity reaction has not occurred. But he is a changed person now. He has no clinical problem up to now, but he is a changed person. Why? Before going to that party and garden, he was not having antipollen IgE, and he was not having any antipollen IgE loaded mast cells and basophils. But now he has a change, and this change takes how much time? It takes about 10 to 15 days. So when he went to the party and the new flowers, new pollens, right, and unfortunately he processed the pollen and presented to the T cells, and T cells were capable of converting the B cell into plasma cell, which produce antipollen IgE, and antipollen IgE is now loaded on the mast cells and the basophils. Whole this process takes 10 to 15 days. So after 10 to 15 days, his body is altered. His immune system is no more normal. His immune system has such type of mast cells and basophils that which are ready to react with the pollen if next time it reappears, Is that right? And now you see, he is planning with his girlfriend to go to the same garden in the late evening times, late hours. Is that right? And it's about, let's suppose, 1 month now. After 1 month of the first party, now you're planning a second romantic type of party, only with you and with your girlfriend, and you're planning to go to the same garden and near the same flowers and probably going to inhale the same pollens, and unfortunately you are not going to have romance because your body has already anti-pollen Ig loaded on the mast cells and basophils, and there can be severe immunological reaction. We'll talk about this after the break.
All right.
Now we'll see, we have talked about how these are formed. Now we sum up what we have discussed already and then continue the story, what happens to Raul when he goes with his girlfriend there, right? We have already discussed that what was there, that pollen grain came, pollen grain was taken up by the macrophage, and then pollen with the class 2 molecule presented to the T helper cells, right? And T helper cells were activated, they released interleukin 4 and convert the B cell and activate the B cells into clonal expansion. Is that right? Many B cells, and then they release interleukin 5, and these B cell converted into plasma cells, and these plasma cell produced IgE, and this IgE was binding with the mast cells. This is what we have already discussed. So this part of the story we are here. Now we'll discuss this into detail. What are mast cells and what are the factors which can stimulate the mast cells, from where they come, where they are present. Is that right? And then we'll see in particular case of Raul what really happens. So let's suppose here's the mast cells. Mast cells. Now mast cells are connective tissue cells, but they are derived from the bone marrow, and similar cells are present in circulation also, and these similar cells are called basophils. These are called basophils, but they are present in circulation in very small amount. So mast cells and basophils are functionally very, very similar, but the very big difference is basophils are moving in the circulation and mast cells are present in our connective tissue, right? But basophils and mast cells both are derived from the bone marrow. Now, where the mast cells are present? Mast cells are present in all the connective tissue of the body, but mast cells are specially concentrated in perivascular connective tissue. Mast cells are specially concentrated, right, around the perivascular connective tissue. It means whenever mast cells will be activated, vessels will react strongly. Mast cells are specially concentrated in perivascular connective tissue. Secondly, mast cells are present in all that connective tissue which is under the internal and external lining, especially in subepithelial connective tissue. Mast cells are specially concentrated around the blood vessels and in subepithelial connective tissue. Subepithelial connective tissue means all the connective tissue under the mucosal lining and all the connective tissue under the skin. So mast cells are specially concentrated under the skin. They are specially concentrated under the skin. Mast cells are specially concentrated, under all this mucosal lining, laryngeal and pharyngeal, right? Even mast cells are well concentrated all the mucosal under the mucosal lining of GIT, right? And mast cells are even well concentrated under the mucosal lining of urogenital system. And of course, now what you learn about mast cells? Number one, mast cell is a connective tissue cell. From where it is derived? It is derived from bone marrow. And we are talking about mast cells that they are derived from the bone marrow. right? And they are well distributed in the body connective tissue. They are specially concentrated around the connective tissue, around the blood vessels. That is why in type 1 hypersensitivity reaction there are strong vascular responses. Then type mast cells are well concentrated around the internal lining, that is mucosal lining of GIT, mucosal lining of respiratory system, mucosal lining of urogenital system. So these type 1 hypersensitivity reactions involve mucosal linings as well. Then mast cells are very well concentrated in the skin, connective tissue just under the skin. So that is why that type 1 hypersensitivity reactions also involve skin reactions. Is that right? Secondly, that what are the factors which stimulate the mast cells? What are the factors which stimulate the mast cells, right? So that mast cell release their product. The factors which stimulate the mast cell, number one is your IgE. I told you Ig is present on the mast cells. Ig is present on the mast cells, and when allergen substance bind with the IgE, right? When allergen substance bind with the IgE, especially if these are two IgE binding on the mast cell, the three IgE, especially those allergens which are multivalent, the allergens which can react with multiple IgE and cross-link the IgE. Look, this is an allergen, right? It could react with multiple IgEs and cross-link the IgEs. This is one of the very strong stimulant to the mast cell. So mast cell can be stimulated by the cross-linking of IgE by the allergens like pollens. Number two, mast cells can be stimulated by C3A and C4A and C5A, right? These substances can also stimulate mast cells. Mast cells have receptor for complement components, right? C5A, C3A and C4A, especially C3A and C5A. Their receptors are present on the mast cells, and when during inflammation C3A and C5A are produced, they can activate the mast cells. Then mast cells can be stimulated by drugs. Some drugs can irritate the mast cells like codeine or morphine, right? Drugs like codeine or morphine, they can stimulate the mast cells. Then mast cells can also be stimulated by the venoms, or for example snake bite, or one of the venom is melatonin from the snake bite, or venom from the bee sting, right, or from the ant sting. So these mast cells can be stimulated by these substances, but especially if you have made IgE against these substances. Is that right? So, but venom of the snake, melatonin, can directly stimulate mast cells. Then mast cells are so sensitive that even physical agents can stimulate them, like cold can stimulate, or heat energy can stimulate mast cells, or physical trauma can stimulate mast cells. Is that right? Even strong sunlight can stimulate mast cells. So what we learn about the mast cells are very, very sensitive. They can be stimulated by so many different factors, and once the mast cells are stimulated, they produce strong inflammatory reactions. They release the product which act as chemical mediators of inflammation. Is that right? So after having said few words about the mast cell, back to Mr. Raul. Then what really happens to Raul? Now we have discussed 1 month back he went to the garden, pollen grains came to his body, pollen antigens was taken up by the macrophages, presented to the immune system, and T cells activated the B cells, and B cell converted into plasma cell which produced IgE, and those anti-pollen IgE were loaded on his mast cells and basophils. Now after 1 month of the previous experience, now he is sensitized. Due to first exposure, he is sensitized against the pollen, right? Because in his body there are mast cells and basophil loaded with IgE against the pollen. Now he is going with his girlfriend to the same garden in late evening hours. We'll see what happened there. right? Actually, as soon as pollens will start going in, they are already pre-sensitized mast cells. So this time, as soon as pollen antigens will touch the IgE on the mast cell will have explosive response, right? They will start producing lot of chemical mediator. Let's see what will happen in his lungs. The reaction is going on within his lungs. And what is happening within his lungs? Okay, lung is too small. This is his bronchial tree, and this bronchial tree is now loaded with the mast cells. These are small mast cells, and these mast cells are, yes, these mast cells are having anti-pollen IgE antibodies on them. As soon as pollens will start coming in, as soon as pollens will start coming in his respiratory system, these mast cells will be stimulated. Now we see what really happened with this mast cells activity. But before we talk about that, let's look at the bronchial histology, because mast cells present in the bronchial system will degranulate and they will produce a pathology there. So let's look at the, I will draw here. These are the epithelial cells in the bronchial, what is this? Mucosa? Mucosal lining, right? And here are some glands. Which gland? Secretory glands, right? And here are some blood vessels in the mucosa and submucosa, especially in submucosa. And then here are, what are these? Bronchial, smooth muscles. Bronchial, smooth muscles. Now this was the bronchial section, and this is what I draw from. Now where the mast cells are present? Let's suppose mast cells are present here. These are the mast cells around the blood vessels and under the mucosal lining near the glands. These are the mast cells, and these mast cells in his respiratory systems are loaded with anti-pollen IgE. And here is the pollen grain with its pollen antigens. These are special antigens, right? Now, these antigens will be presented to the mast cell and mast cell will be activated. I will bring one mast cell here to show what exactly happened with the mast cell. This is mast cell membrane, right? Here are the receptor. Which receptor? Receptor for Fc portion of IgE. These were antipollen. These are antipollen IgE. These were antipollen IgE, and these are the receptors, mast cell receptors for antipollen IgE. Now here are the antigenic domain of pollen grain, and this is the allergen or antigen. This is polyvalent antigen which react with multiple, what is this? IgEs on the surface of the mast cells, and these are now cross-linked. What has happened with them? This is the pollen. This is the pollen grain, very happy. He conquer all with his with his girlfriend. Right? Now this is the pollen antigen, and these are multivalent antigenic point which cross-link the IgE. As soon as IgE is cross-linked, multiple reaction will occur. Number one, intracellular, intracytoplasmic signals will come, and within the cells there are granules. There are granules present in the mast cells, and there will be signals going to cytoplasm, cytosol, and these granules will come to the surface and they will start releasing their products. These granules will start releasing their products. Is that right? These are preformed products. The products which will be released from here are histamine. Histamine will be released from there, from mast cell granules, right? And along with the histamine, there will be proteases, proteolytic enzymes. These enzymes can break down the proteins. Along with that, some preformed neutrophil chemotactic factors and eosinophil chemotactic factor. So neutrophils will love to come there. Now mast cell is calling, mast cell is activated, and it is calling neutrophil, as well as it is giving a special call for eosinophils. Neutrophil chemotactic factor and eosinophilic chemotactic factor. Meanwhile, these proteases will do two things. Number one, they will do further tissue damage, and when tissue is damaged, more inflammatory mediators will be produced. Inflammatory mediators will be produced. Number two, proteases will convert some complement like C3 or C5, and these proteases will convert, and C3A will be generated and C5A will be generated. C3A and C5A, they do have receptors on the mast cell. These are the receptors for what? C3A receptor or C5A receptors. When C3A and C5A are produced more and more in the site of activity at reaction site, of course reaction site is bronchial wall. In the wall of the histamine, within the bronchial wall, they are stimulated. So this is the reaction site. So they have locally lot of C3A, C5A is produced, and when this C3A and C5A will act on the mast cells, right, they will further stimulate the mast cell. So it means it's a local amplification loop, that once mast cell is activated, it releases proteases. Proteases break down the produce active complement factors. Some of the active complement factors do have receptor on the mast cell, and mast cells are stimulated further. Is that clear? Secondly, there is histamine. Now histamine has many functions. Number one, histamine is vasodilator. So these blood vessels, look at these blood vessels, they will be dilated. These blood vessels will be dilated. Number two, and under the direction of histamine, endothelial cells will shrink. When endothelial cells will shrink, that will produce increased permeability of micro area. So when this will become more permeable, so naturally this vessels will become, as they're dilated and more permeable, so edema formation will develop in submucosa. What will happen? That edema formation will develop, fluid will start coming out of mucosal vessels from the local vessels, and edema formation will start, right? So there's increased permeability. Thirdly, they are strongly spasmogenic. Now look at it, that spasmogenic, there are histamine receptors which are present on what? These smooth muscles. So histamine will act on these smooth muscle and they will become spastic. Now you see, blood flow in this area is increasing. Blood flow in this area is increasing. There is edema formation there. Is that right? At the top, now it means submucosa will swell up. It will swell up. So lumen will be reduced. When submucosa will swell up with the edema, and right, lumen will reduce. At the top, histamine has led to the bronchial smooth muscle contraction that further reduces the lumen. Now it's a difficult time coming for him. Can he breathe well? He cannot, right? So at the top, histamine can stimulate glandular secretions. Glandular secretions. So even in the lumen, these glandular secretions are becoming more. These glands are producing more secretions, right? And when glands are producing more secretion, it means there's luminal obstruction, there's mucosal and submucosal swelling, and there's bronchoconstriction. All these factors are reducing the airway caliber. And this type of reaction is occurring into multiple sites within the bronchial tray, right? This type of reaction is occurring into multiple sites within the bronchial tray. This reaction, which is occurring so fast and rapidly, this is called initial phase reaction. What is this? Initial phase reaction. And these preformed substances which are released by the granules, these substances as a group are called primary mediators. That is histamine, the primary mediator, proteases, the primary mediators, and neutrophil and eosinophilic chemotactic factors, these are called what? These are the primary mediators. So we can say that as a group, all these should be called, yes, all these should be called primary mediators of type 1 hypersensitivity reaction. Primary mediators. What are primary mediators? Primary mediators are preformed chemical substances, right, present within the mast cells, and they can be immediately released. Is that right? Secondly, the second reaction will occur, that is to the nucleus. Let's suppose this is a nucleus, and in the nucleus this genetic material, and what really happens, second pathway, signal pathway is going to the nucleus, and the nucleus is stimulated naturally. It will produce messenger RNA. Nuclear activation will activate the different genes. It means mast cell genomic program is now activated, and this will take some delay, right? And then it will produce messenger RNA, of course, ribosomes, and production of what? Peptides, and those peptides will be thrown into Golgi apparatus, endoplasmic reticulum and Golgi apparatus, and eventually this cell will start releasing certain small soluble protein which act as messenger in between the cells. Now, when nuclear machinery of the mast cell is activated, right, nuclear machinery directs the synthesis of small soluble proteins which are secreted by the cell. These small soluble proteins are going to act as signaling molecule in between multiple cells. As a group, these small molecules are called cytokines. So what are cytokines? Cytokines are group of small soluble proteins which are secreted by many cells in the body, including the mast cells. And these cytokines, right, they act as signaling molecule or communication system or messenger system in between the different cells, right? Now there are many types of cytokines which are produced by this, but these cytokines are not preformed. Because these cytokines are not preformed, so these are not called primary mediators. This group of cytokines are called secondary mediators. And these cytokines are like tumor necrotic factor, which is released by mast cell, interleukin 1, interleukin, there are many interleukins which are released, interleukin 3, interleukin 4, interleukin 5, interleukin 6. It's not difficult to remember, just omit the interleukin 2. So interleukin 1, 2, 3, 4, 5, 6. Then granulocyte, monocyte, colony stimulating factor, right? Granulocyte, monocyte, colony stimulating factor, and macrophage inflammatory peptide. You're not supposed to remember all of them. But at least the minimum you have to remember is interleukin 3 especially, and you should have a special interest in interleukin 5. You know why? These are the special molecules which call the eosinophils. These are the special molecules which will call the eosinophils, because eosinophils should come at the site. No, there was already eosinophilic chemotactic factor that was preformed, so that was part of primary mediators, right? But many interleukins are produced, cytokines are produced as secondary mediators, right? And out of these secondary mediators, interleukin 3 and 5 are specially, you can say, chemotactic for the eosinophils, so that eosinophils should start coming to this area. These are the eosinophils. So neutrophil will be coming there, eosinophils will be coming there. Later on we'll find neutrophil, eosinophils, the lymphocytes, natural killer cell, all these inflammatory cells will come at this site. And this process of cellular activity, that cells, inflammatory cell accumulate at the reaction site, this takes half hour to 2 hours. And then this continues for half hour to 24 hours. And this inflammatory cell accumulation and their strong damaging reaction may continue for many days. That is called late phase. So why there is a late phase reaction in type 1 hypersensitivity? That is due to accumulation of inflammatory cells at the reaction site. And early phases in type 1 hypersensitivity reaction, early phase or initial phase or immediate phases due to vascular events, due to vasodilatation, increased permeability, due to vascular events, plus spasmogenic event. Again, remember, in type 1 hypersensitivity reaction, there are vasogenic products produced and spasmogenic product produced. These vasogenic and spasmogenic product, they produce initial phase of the problem, and eventually a lot of cytokines are produced locally, and many other chemotactic factors are produced which call a lot of inflammatory cells there. So a lot of you can say eosinophils accumulate there. Eosinophils especially attracted by the most strongest chemotactic agent for eosinophil is interleukin 5. So interleukin 3 and 5 are produced by mast cell, and you should not forget your old friend, T helper 2, that could also produce interleukin 5, that can also produce interleukin 3. So interleukin 3 and 5 will be produced by T helper 2, as well as they will be produced by mast cells, and both of them will be calling eosinophils. At the same time, under the influence of all these cytokines, even epithelial cell will start producing a substance called eotaxin. Eotaxin. Now look at this. This is the queen of the type 1 hypersensitivity reaction. What is this queen? This is eosinophil. Eosinophils have bilobed nucleus. Eosinophils have bilobed nucleus, right? They have bilobed nucleus, and this is 3 and 5. You can say they have a glasses number 3 and 5. They are attracted by interleukin 3, and they are also attracted by interleukin 5, and they have a nucleus. The eosinophil has a nucleus like glasses, spectacles, and here is interleukin 3, here is interleukin 5, right? So interleukin 3 and 5 attract the eosinophil at the site of reaction, and these 3 and 5 are produced, interleukin 3 and interleukin 5, they are produced by number 1 T helper 2, plus they are also produced by mast cells. So together they call eosinophils. But we should not forget, even epithelial cell produce eotaxin, a product which also stimulates the eosinophil arrival. So it means as time will pass by, eosinophils will start coming over there due to cytokines and chemoattractant produced by T helper cells, from the mast cells, and even from the epithelial cells. Even from the epithelial cells. Is that right? Now, one thing which is very important is to understand one more aspect, that we have learned that one signaling pathway will lead to cytoplasmic stimulation and release of preformed primary mediators. Second, another signaling pathway that stimulated the nuclear machinery, and that has led to the release of cytokines as secondary mediators. Is that right? Then another, you can say, signaling pathway is stimulating the, what is this? Cell membrane. It was going to cytosol. It was first pathway was going to the cytosol, second signaling pathway was going to the nucleus, third pathway is stimulating the mast cell membrane. And within the mast cell membrane, there is a very special type of what? Enzyme, and this enzyme is called phospholipase A2. Within the mast cell membrane, there is a special type of enzyme called phospholipase A2, and this phospholipase A2, when it is stimulated, this will break down the phospholipid in the membrane, right? This will break down the phospholipids in the membrane, and those phospholipids will be broken down into, under the direction of phospholipase A2, phospholipids will be broken down into arachidonic acid. They will broken down into arachidonic acid. So as soon as mast cell is stimulated, lot of arachidonic acid produced within the mast cell membranes due to activation of phospholipase A2. Is that clear? Now this arachidonic acid will be acted upon by more enzymes which are present within the mast cell membrane, and those enzymes can take this arachidonic acid through two pathways. Those enzymes can take the arachidonic acid into two pathways. Some of the arachidonic acid will go into lipooxygenase pathway. Lipooxygenase pathway, and other enzyme will take it along the cyclooxygenase pathway. Cyclooxygenase pathway. Now what really happens? That along the lipooxygenase pathway, there will be production of different type of leukotrienes. What are substances produced? That arachidonic acid will progressively broke down into final product, and the final products will be leukotriene B4, leukotriene C4, leukotriene D4, and leukotriene E4. Now you have to remember one thing. This leukotriene B4 is a strong chemotactic agent for neutrophil. This is leukotriene B4 is a strong chemotactic agent for neutrophils. So it means many neutrophil will come into this area. Now you see what is happening here. Very big tragedy. That there's a lot of accumulation of blood vessels are dilating, microcirculation is becoming more permeable, edema formation is going on, glandular tissue is stimulated, and more secretions are coming, right? Secretions are obstructing the lumen, and submucosal swelling is also reducing the lumen. At the top, many substances are acting as spasmogenic and producing. Now, you know what is the most powerful spasmogenic in the world known? What is the most powerful spasmogenic known? Please tell me, what is the most potent vasoactive and spasmogenic agent? What is the most powerful vasogenic and spasmogenic substance? I mean the substance which can strongly act on vascular system and strong edema is produced, and substance which can strongly act on smooth muscles and produce very powerful construction. That substance is thousands of the time more potent than histamine. I think good doctors should know that. Even I've written it on the board. This substance is leukotriene C4, D4, E4. As a group, they are the most potent vasogenic and spasmogenic agents known up to now. So what does it mean? Raul is going into big trouble. So powerful spasmogenic are produced. Forget about histamine. More things are now coming. Already histamine was producing spasmogenicity. Now at the top, slow, previously these were called slow reacting substance of anaphylaxis, right? But anyway, a C4, D4, E4, they produce now very powerful bronchoconstriction and spasticity. At the top, these three substances are very strong stimulant to endothelial cells. Endothelial cells shrink, interendothelial gaps are appearing, and too much edema is forming. You understand what is happening? That already histamine was working against you. Is that right? And now leukotrienes are also working against you. Meanwhile, cytokines are accumulating many cells. Is that right? So there is repeatedly what is happening. The waves and waves of chemical mediators are coming, producing vasodilatation, increased permeability, more you can say edema, right? Stimulation to what is this? Glandular secretions, spasmogenic activity, all this is deteriorating his respiratory system function, right? By this time he's feeling cough, he's finding difficult to breathe, and at many points what is happening, that bronchial tree is slightly spastic, and when air passes through slightly narrow areas, some whistling effect occur, and he may start producing some whistling and some dyspnea. That whistling is called wheezes, and his girlfriend is not a medical student. She may think, start looking around, maybe he is trying to whistle some other girls. She is not understanding, he is in trouble, and he is trying to be champion, behaving, nothing is happening to me, but very soon things are going out of his control, right? So what is happening to Mr. Rao, that he is coughing. With that, he has developed difficulty in breathing, unpleasant awareness of breathing process, right? We call it dyspnea. And with that, because bronchial spasticity at multiple area make the bronchial tree as small narrowings, and multiple narrowing mean that as multiple whistles have been planted in his airways, and he start developing whistling sounds, especially during expiration. Is that okay? Now story is not yet over. Meanwhile, what happened, that through the cyclooxygenase pathway, prostaglandin pathway is continuing, and the most important prostaglandins which are produced over there are, yes, D2, E2 and F2, but most abundant prostaglandin which is produced by the mast cell is PGD2. This prostaglandin is now abundantly accumulating, being produced by the mast cell membrane product and accumulating here. This is strong vasodilator. This is very strong, you can say, micropermeability increaser, but more importantly, it's very strong stimulant for the glands. So these glands start secreting more and more product. So glandular secretion increase, vasodilatory effect is there, right? And this further aggravates the situation. Is that right? Now let's see what is happening. Meanwhile, you should not forget, another product is coming into game, and that is platelet activating factor. This is also derived from the membrane lipid. Platelet activating factor is also derived from the membrane lipid, and its mechanism of action, to remember what it is doing, is most easy. It does everything, which is what all other together are doing. It can produce vasodilatation, it can produce increased permeability, it can produce more histamine release, it can stimulate the mast cell, it can, but most important thing, even though that platelet activating factor by name you can see it, it can aggregate the platelet, it can act on the mast cell and release more histamine. It is very strong bronchospastic agent. Now look at it, the poor Raul. The bronchospasticity by histamine, bronchospasticity by the leukotrienes, bronchospasticity by the platelet activating factor, then vasodilatation further by an increased permeability by platelet activating factor. But the most important factor is that platelet activating agent act as very strong chemotactic agent. It means they will also call lot of inflammatory cell. It means when more cytokines production and platelet activating factor production will activate the late phase, because late phase of the type 1 hypersensitivity reaction is, you can say, has a hallmark of accumulation of lot of inflammatory cell at the site of reaction. That is why for early phase these are the vasodilatory actions and spasmogenic action and increased permeability action. The early phase of type 1 hypersensitivity is due to vasodilatation and increased permeability, edema and flare. You can say increase blood flow, increased permeability, more edema formation, and early phase there is bronchospasticity. That is why early phase is mainly histamine dependent or leukotrienes dependent. Is that right? Late phases, especially by accumulation of inflammatory cell. Inflammatory cell, why they accumulate? Inflammatory cell accumulate because in the beginning neutrophilic chemotactic factor is released, eosinophilic chemotactic factor is released, then lot of cytokines are released. They are calling lot of inflammatory cells. You remember interleukin 3 and 5 specially call eosinophils. Neutrophils are there, macrophages are coming there, lymphocytes are also coming there. Do you think it's all good news for its tissue? Because all these inflammatory cells will come and produce their dangerous product and further damage the situation. And these inflammatory cells will damage the, what is this? Epithelial cells. Epithelial cell injury will be there. Is that right? And even epithelial cells are so stupid. They don't sit innocently. Epithelial cells start releasing themselves chemical mediators. Epithelial cells start releasing themselves chemical mediator like eotaxin and like interleukin 3-5 can also be produced by epithelial cells. It means epithelial cell also enhance the whole situation. Is that right? Now, under all these circumstances, what will happen that there will be severe tissue damage as time will pass by. Especially don't take eosinophils lightly. Eosinophils can produce two very dangerous products. One is basic, yes, eosinophils. Number one, they produce cationic proteins. Eosinophil produce positively charged proteins. We call them eosinophil cationic protein. Other thing they produce is major basic, what is that? Major basic protein. This major basic protein and eosinophilic cationic proteins, these two are very dangerous because they can damage epithelial cells and many other cellular components around the or near the or within the reaction site. Is that right? So how many players are in this game? So many. Is that right? Again, listen, let's start thinking of the players. The first player was, remember, first player was your antigen presenting cell. That was your first player. Second player was T helper cells to which antigen was presented. Third player was B cell converting into plasma cell and producing IgE. Fourth player was basophils, the real player. Oh, sorry, mast cell, the real player, because they bound the IgE. So 4 number player is the most important player. That was a mast cell, because mast cell release lot of chemical mediators. 5 number player was, who was coming there? Eosinophils. Eosinophils, the inflammatory zone. And then 6 number neutrophils, 7 number macrophages, all inflammatory cells are coming. And please don't forget your friend who was so stupid to do themselves further damage, and these are epithelial cells, mucosal epithelial cells, right? And a lot of chemical mediators are produced. In this game, these chemical mediators which were preformed like histamine, proteases, and neutrophil chemotactic factor and eosinophilic chemotactic factor. These three things, these are primary mediators. But cytokines are secondary. In the same way, leukotrienes and prostaglandins are secondary mediators because there's de novo, there's new synthesis of the product. Platelet activating factor is secondary mediators. So mast cell produce primary mediators as well as secondary mediators, and mast cell along with other inflammatory cell and epithelial cell produce so much chemical mediators of inflammation that there is increased vasodilatation, there is increased permeability, there is edema formation, there is you can say swelling of the submucosal, submucosal area, reduction in the lumen at the top, increased secretory activity by the respiratory glands, so that will lead to further occlusion of the lumen, and many of them like platelet activating factor, like your leukotriene C4, D4, E4, like histamine, all of them can produce really very powerful spasmogenic action. So he will develop this problem, and very soon what will happen? That his girlfriend will realize he is under trouble, he is not whistling to other girls, maybe he is in a very serious problem because whistles are not coming from the mouth, they are coming from the chest. Is it right? Now, what she will do? Leave you and run away, or she will take you to hospital? You are not sure. Somehow you have to be sure, right? So what do you think, Yara? Most of the girls' friends, they do what under these circumstances? That, yeah, that they call 911. That take this culprit to hospital. Okay, so she's an intelligent girl. She knows what girls will do. They will call 911. But don't hand over the boy to those people. Tell them that he should go to the emergency, right? So they will take him to the emergency. Then you know what they will do, that hopefully if they are having oxygen, they will put there, right? If they are having bronchodilators like salbutamol, they will nebulize to him. And of course, with that, they must give steroids. Antihistamines substances are usually not given, but in anaphylactic shock they are given, right? And especially they will give steroids. The steroids are very useful to prevent the late stage. It depends on the inflammatory cell activity. Is that right? Because if you give the steroid to the patient, then naturally accumulation of eosinophils and neutrophils and lymphocytes and accumulation of monocytes, macrophage, all these inflammatory cells accumulation will be prevented or suppressed. Is that right? Like prednisolones, like solocartef. I mean, of course, if he's under severe trouble, they will give intravenously parenteral steroids, right? Now, a few more important points related with the type 1 hypersensitivity reaction. Already we have taken example of Raul, that how he developed type 1 hypersensitivity reaction to allergy, pollen grains, and that was actually leading to what problem? That was leading to asthma. That clinical pathological condition is asthma. Now listen, asthma. Now, the important point which you have to remember, that different people develop different types of hypersensitivity reactions. Some hypersensitivity reactions are localized hypersensitivity reaction, localized type 1 hypersensitivity reaction, and some people develop generalized type 1 hypersensitivity reactions, and some unfortunate people develop both types. Now, examples of localized hypersensitivity reaction, where for example there are so many, you can say, environmental allergens, right? For example, there's dust, or there are pollen grains, or there are dander of the you can say from bird's feather, or some people develop from something from the horse, right? There's so many factors or allergic substance. It depends on against what substance a particular patient is making IgE. Is that right? Now, there's so many types. Let's talk about that. If you are having, let's suppose, anti-allergen IgE on the mast cells present in the conjunctival mucosa, then you will develop allergic conjunctivitis. Allergic conjunctivitis. Some people, they have IgE loaded mast cells in the nasal mucosa against the allergens, and if they are inhaling the allergen, they will develop allergic, yes, rhinitis, allergic rhinitis, right? Then there are some people, they develop, swelling of the lips and nasal swelling of the lips. With that, there's swelling in the larynx and pharynx, and all that swelling in response to some allergic substance, that is called allergic angioedema. That is called angioedema, right? Then there's another condition which is called hay fever. Have you heard of hay fever? This is another allergic situation in which person develop allergy or type 1 hypersensitivity reaction in the conjunctiva, type 1 hypersensitivity reaction in nasal mucosa like sneezing, and type 1 hypersensitivity reaction in the larynx and pharynx also. So when someone has type 1 reaction only in conjunctivitis, he develops red eyes. Is that right? And itching in the eyes. Someone develop allergic rhinitis, itching in the nose, right? And with in the lecture I keep on touching my nose. Have you noted it? Actually, I have allergic rhinitis.
I have conjunctivitis.
And when I'm not taking the drugs, I keep on somehow adjusting my nose appropriately. Probably there's allergy in the nose, which keep on reminding some itching there. Thank God I have allergy in the nose. I move only my nose, right? Then you have allergic conjunctivitis. So maybe you are too much sensitive about your eyes. Then angioedema is really bad because the severe swelling of the lips, the fleshy margins around the oral cavity, right? Lips and swelling of the, you can say sometimes oral mucosa, but most importantly in angioedema, there may be life-threatening swelling of laryngeal mucosa, right? And that laryngeal mucosa may lead to life-threatening situation. In hay fever, someone has developed type 1 allergen in which he develops, you can say red eyes, he develops sneezing, and patient develops also a sore throat type situation, and with that laryngeal swelling, laryngeal and pharyngeal allergic reaction. And if reaction goes more deeper, that may become allergic asthma. Allergic asthma. Then type 1 hypersensitivity reaction may be related with the skin. Many people who are allergic to common environmental substances, when they come across the allergen, they may develop on the skin. There are, red patches, or you can say hives, right? Or patient may develop erythematous rashes on the skin, right? Or some reactions like wheal and flare and wheal, right? Or some urticaria. So all these are the allergic reactions, type 1 hypersensitive reaction in the skin. Then some people develop in the GIT. Many examples of the food allergy. Is that right? There's someone who take a special type of food, and if all the GIT mucosa is loaded with anti-allergen IgE on the mast cells, then mast cells in the GIT will degranulate and produce the product. Patient will develop abdominal cramps and diarrhea maybe, right? In the same way, you must be knowing someone who has allergy to egg. So actually, you can develop allergy to anything depending upon your capacity to make IgE against that particular environmental substance or not. And right, so there can be skin allergies, respiratory allergies, there can be GIT allergies, right? These are all examples of localized allergy. These are all examples of localized allergic reaction. Opposite to that, some people develop, unfortunately, systemic allergy, type 1 hypersensitivity reaction. The classical example I can give you, someone who developed IgE against the penicillin, right? And he has developed sensitivity to penicillin. So what really happens that if you give test dose of penicillin, the patient usually develops a localized allergic reaction like wheal and flare. But if unfortunately without the test dose you have given a good dose of, unfortunately a good heavy dose of penicillin in the intravenous system, not only heavy, even small dose can do the unfortunate thing that all the mast cells around the cardiovascular system will degranulate, and when all the blood vessels will dilate, and you can say all the microcirculation will start losing the fluid, so patient will go into shock, and this shock is called, yes, anaphylactic shock. Anaphylactic shock. Anaphylactic shock is an example of systemic hypersensitivity reaction. And in these patients, of course, when you have given parenterally the allergen, right, not only all the blood vessels dilate and increase permeability and blood pressure drops, under the skin also all the mast cells degranulate. When so many mast cells under the skin degranulate, that will produce what type of problem? Yes, patient will develop urticarias and red rashes. Is that right? So this person will develop rashes, he will develop falling blood pressure, and naturally when respiratory system mast cell will degranulate, this person will develop difficulty in, yes, difficulty in breathing. So, and if GIT mast cells degranulate, this person will also develop abdominal cramps, right? Abdominal pain, visceral pain in the abdomen, or abdominal cramp, right? So this type of multisystemic and IgE mediated mast cell dependent reaction can occur with multiple allergens which are given intravenously. As I told you, it can occur with injection of the drugs, it can occur with injections of hormones. If you inject some peptide hormone to someone and a person has already pre-sensitized against that particular peptide hormone and person has made IgE against that hormone, as soon as you inject the hormone, person will go into anaphylactic shock, right? In the same way, this can occur with enzymes, injections of enzymes, injections of hormone, or injections of foreign proteins like anti-sera, or injections of drugs or polysaccharides, right? So this may produce itching on the skin and hives, skin erythema, respiratory distress and abdominal pain, and eventually cardiovascular collapse. And if you don't do some heroic measures, patient will die within an hour, right? So the management of that patient you will learn in shock. Another important thing is that there is a special type of desensitization therapy. You know what is desensitization therapy for type 1 hypersensitivity? Actually what we do, that if we give the, under supervision, we give extremely small amount of allergen parenterally if patient can tolerate. We give extremely small allergen, and if we keep on giving repeatedly small amount of allergen, patients start making IgG against the allergen. Patient was previously making IgE, and if you repeatedly challenge the immune system, patient may start making IgG. So if patient circulation become very rich in IgG, this is the immune headquarter, and previously it was through this door it was making IgE, which is loaded on the mast cell, and here it is making IgG. So repeated exposure of the immune system and very small amount of allergens, slightly progressively increasing doses may make IgG. The next time when allergen comes, it may bind with IgG, and IgG will block the allergen approach towards IgE. So these are blocking IgG antibodies which are produced, right? This is called desensitization therapy. What is desensitization therapy? In type 1 hypersensitive patient, we give progressively increasing small doses of allergens so that patient may develop anti-allergen IgG, not IgE. And if patient successfully develops anti-allergen IgG with repeated injections, levels of IgG are boosted, secondary immune response. And if IgG levels are significantly boosted, the next time when allergen will come, IgG will bind with the allergen and block the approach of allergen to the IgE, and patient will be prevented from severe anaphylactic reaction or type 1 hypersensitivity reaction, right? Then, and a few more points, that how do you diagnose type 1 hypersensitivity reaction? One of the tests is skin prick test. Skin prick test, that under the skin you inject extremely small amount of allergen, and if wheal and flare is formed there, it means localized mast cells are degranulating, right? It means person is allergic to that particular substance. Secondly, skin prick test, right? Or some people call it scratch test, that a specific allergens are injected just under the skin and will look for formation of wheal and flare reaction, right? If this reaction is there, then it means that there is type 1 hypersensitivity against this particular allergen, as wheal and flare reaction is due to localized mast cells degranulation and other chemical mediator production. Then another test is RAST test. RAST stand for radio, yes, radio allergo immunosorbent test. Should I write? RAST stand for radio allergo immunosorbent test. Now, I will not go into detail of this test. Detail we'll study in other lectures of immunology, where we study the antigen antibody laboratory test. Only I'll mention that RAST test is used to detect a specific, this test is used to detect specific IgE against a particular allergen. For example, if you want to see you have antipollen IgE or not, or you are having IgE against a particular drug or not. So the test which is done is RAST test, right? Another simple test which is non-specific is, of course, in most of the patients who have type 1 hypersensitivity reactions, they are having higher level of IgE in the blood, and they are having higher number of eosinophils in the blood. Now another thing which I want to mention is the concept of atopy. Have you heard of the concept, the word of atopy or atopic tendency? Atopy is a familial tendency, write it down. Atopy is a familial tendency to make IgE more frequently. Atopy is a familial tendency to make IgE more frequently against the common environmental substances, IgE more frequently against the common environmental substances to which most of the population is inert, or to which most of the population is non-reactive, right? So in some families it's like this, that father is allergic to, multiple family members may be allergic to different things. Maybe son is allergic to soap, daughter is allergic to toothpaste components or makeup substances, right? Maybe mother is allergic to nylon, and maybe father is allergic to mother, right? So when situation like this occur, last example, ponder over there, think over that, right? That when multiple family member may be developing allergy to multiple different environmental substances to which most of the people are inert, we say there's atopic tendency in that family, right? So secondly, recently they have started looking for, that is, what is the genetic component in atopic tendency. They believe at chromosome number 5 there are some genes which are related with development of allergy. Actually at chromosome number 5, especially that cluster of genes which is related with synthesis of lot of interleukin cytokines. At chromosome number 5 there is a special locus at which there are multiple genes to synthesize the interleukins. Probably in someone, if interleukin 4 is produced more, he has a higher chance to develop type 1 hypersensitivity reaction. Then some other people have suspecting that some genes at chromosome number 6 near the HLA cluster, they are related with the type 1 hypersensitivity, because of course it's very understandable, if you have inherited such type of MHC or HLA genes which are making such class 2 molecule, which are processing and presenting more commonly environmental substances, you have higher chances to develop type 1 hypersensitivity reaction. Are you understanding, or I should repeat it? That if you have inherited such type of MHC genes which make such type of class 2 molecule which can bind and present common environmental substances, you will have a tendency to develop allergy. So to develop type 1 hypersensitivity reaction, these people have a high tendency to have such type of class 2 molecule which can bind with the common substances and present to the immune system. Secondly, these people have higher